Hi everyone, my name is Catherine Galloway and I am presenting with Abigail Dunphy on delirium. So first I'm going to go over what delirium is, and then I'll have a short video for you to watch which shows delirium and how it's presented. So delirium, one way I like to think about it is just imagining if someone is very confused, doesn't seem to be hearing or seeing the same things that you are, and they may be agitated, or on the other hand, they might just be quieter than usual and just very out of it. I know that I have seen these symptoms in many times in like older adults, and I just didn't know what it was. But now that I have seen the video, and which you'll see, um, it it I can see how it could be frustrating or confusing for the caregivers. The onset of delirium is usually very quick, and the duration is short. And it can always be directly related to another medical condition, medication, and or substance use or withdrawal. It's most common in older adults, and it can be easily missed and attributed to dementia or other neurocognitive disorders. Like I said, it almost always occurs in the context of an underlying neurocognitive disorder. It also disturbs the sleep-wake cycle. So it might be reversed, so people are sleeping all day and up all night, or just sleeping more than usual, or just having fitful sleep. And then also along the same lines, the conditions tend to worsen at night. So someone is going to be more anxious at night, more fearful, more depressed. Those are just really going to be strong at night, even if they're present during the day. They're really going to be more pronounced in the evenings and night. The good news about delirium is that full recovery can be achieved for most people, and the sooner the condition is detected, the faster and more easily it can be treated, and the better the prognosis. The older the individual is at the time of diagnosis, is the more likely that the delirium will worsen their overall condition. So since it is most prominent in older individuals, it can be not detrimental, but it can cause other conditions not to worsen, but in conjunction with other conditions that are going on, it's just not a very good thing for them to have going on. Let's see. And chances of hospitalization and institutionalization, such as going into a nursing home, increase greatly for older adults with delirium. As I mentioned, it's very hard to differentiate between delirium and dementia. According to the APA, the traditional distinction between delirium and dementia, according to acuteness of onset and temporal course, is particularly difficult in those elderly individuals who had prior neurocognitive disorders that may not have been recognized, or who developed persistent cognitive impairment following an episode of delirium. So it's important to know somebody's history, but then also to follow through with those individuals that do experience delirium and keep track of what their neurocognitive disorders are moving forward. Other differential diagnoses include psychotic, bipolar, and depressive disorders, because similar symptoms may include things like hallucinations, agitation, confusion. Acute stress disorder is a differential diagnosis, which would be the result of a trauma. And then there's some chances of malingering or factitious disorder, but that should be easy to find out, determined on if the presentation of delirium is atypical, or if there's not another underlying condition, then you can understand that it would be malingering or factitious. So I'm just going to go over the diagnostic criteria for delirium from the DSM-5 real quick. A is a disturbance in attention, such as reduced ability to direct, focus, sustain, and shift attention, and awareness, which is reduced orientation to the environment. B, the disturbance develops over a short period of time, usually hours to a few days, represents a change from baseline attention and awareness, and tends to fluctuate in severity during the course of the day. C, an additional disturbance in cognition, such as memory deficit, disorientation, language, visuospatial ability, or perception. D, the disturbances in criteria A and C, which are a disturbance in attention and awareness or an additional disturbance in cognition, would not be better explained by another pre-existing, established, or evolving neurocognitive disorder, and they do not occur in the context of a severely reduced level of arousal, such as a coma. And E, there's evidence from the history, physical exam, or lab findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, such as a drug use or abuse or a medication, or exposure to a toxin, or due to multiple etiologies. So those are the diagnostic criteria from the DSM-5. And then next you can click on this link and it'll take you to the video. I chose this video because it gives a good example of what it would look like in real life. And it gives two examples. The first example is if somebody were really out of it and just not acting like themselves and clearly not seeing and hearing the same things that those around them are. And then the second part of the video is it presenting as someone who's very agitated and upset and just not acting themselves. So it gives a good example of what it would look like in a real life situation, and I found it helpful, and I thought hope you will too. So that concludes my portion, and then after the video, you can click on Abby's link, and she will walk you through the article and her web resources. Thanks.